Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Today we are digging into the high lung shunt playbook.
And the goal here is to move past just knowing the scary numbers.
Yeah.
I mean, any first-year resident can quote the safety guidelines.
Sure.
We want to understand how to manage high lung shunts, what the real risks are, and specifically what mitigation techniques you have in your back pocket when a patient exceeds those limits.
Because simply canceling the case isn't always the only option.
And sometimes it's the wrong option for the patient.
So let's unpack this. Before we get into how to fix it, the balloons, the coils, all that, we have to talk about what we're actually afraid of.
Right.
What happens if you just ignore the shunt and treat anyway?
Yeah, we're talking about radiation pneumonitis, or RP. This is the critical context.
Right.
And what makes RP so tricky and so dangerous is that it is not an immediate catastrophe. You don't inject the Y-90 and watch the patient crash on the table. It's not like that.
It's a slow burn.
We are talking about an onset of 1 to 2 months post-procedure, sometimes even longer.
Yeah.
The patient goes home, they seem fine, maybe a little fatigued.
And then weeks later they show up with a cough.
Exactly. Dry cough, shortness of breath,
Right.
and radiographically it has a very specific look if you happen to catch it on a CT.
It does, right? I remember seeing images of this.
It's often described as a bat wing appearance.
Yeah.
You see these ground glass opacities.
Yeah.
But interestingly, they have perihilar and peripheral sparing.
So the damage is concentrated right in the middle zone of the lung. Why there? Why not the edges?
It just comes down to physics and anatomy. The Y-90 microspheres are a specific size. They travel through the pulmonary circulation until they get stuck.
Oh, okay.
And mathematically, they tend to lodge right at the 15th order arterial. That vessel size just happens to be dominant in that middle zone of the lung parenchyma.
So they get stuck, they emit radiation, and you get fibrosis.
Correct. And here is the kicker, and this is why IRs lose sleep over this. The incidence is incredibly low.
How low?
We're going 0.1%, 1 in 1,000 patients.
So it's rare. You might go a whole career and never see it.
You might. But the mortality, it's between 40 and 60%.
So if it happens, it is basically a coin flip if the patient survives.
Exactly. High lethality, low incidence. That is the definition of a high-stakes complication. And that is why we have these strict rules about lung dose, because the penalty for breaking them is just so severe.
Okay, let's talk about those rules. The instructions for use, the IFUs. Every IR knows these numbers, but let's just refresh so we're on the same page.
Sure. So if you're using glass microspheres, the limit is 30 gray as a single dose.
30 gray. Got it.
If you're using resin, it's also 30 gray for a single dose, but there is a cumulative lifetime limit of 50 gray. Also, resin has that hard stop. If the shunt is over 20%, it's technically contraindicated.
Right. But here is where it gets really interesting. These numbers, 30 gray, 50 gray, they feel like laws. But when you dig into the source material for this, their origin story is actually a little shaky, isn't it?
We base our entire safety profile on these numbers, but they are essentially derived from studies that are 25 years old.
25 years old.
Specifically papers by Ho and Liang. And when you look at the sample size, it was 95 patients.
95, that's it. That's the entire data set.
That is the data set that built the global standard of care. And it gets even more extrapolated. The original safety data wasn't even purely from Y-90. It was pulled from external beam radiation studies from like the 50s and 60s, where they set a whole lung limit of 25 gray.
But external beam radiation is totally different from injecting radioactive particles, right? That feels like comparing apples to, I don't know, tiny radioactive glass beads.
It is biologically very different. External beam is uniform, it hits everything. Particles are brachytherapy, they are focal, they create little hotspots.
Oh.
But in those original 95 patients, what they found was that 1 out of 3 patients who got more than 30 gray developed RP. And 1 out of 2 who went over 50 gray cumulative got it.
Okay, so even if the sample was small, the signal was real.
The signal was real, yes. But the takeaway is that these guidelines are, frankly, antiquated. They are the standard of care. You have to follow them, but scientifically, they're a blunt instrument.
So knowing the rules are blunt but mandatory, let's talk about predicting the problem. How do you spot this before you even order the MAA? Can you predict a massive shunt just from the diagnostic scans?
You can. You can develop what the source calls a clinical eye. There are characteristics that just scream high shunt if you know what you're looking for.
Okay, what are we looking for?
First, just look at the tumor burden. If you have a massive tumor, say greater than 50% of the liver volume,
Yeah.
or an infiltrated tumor type that doesn't have nice borders, your risk goes way up.
The vasculature is just chaotic.
It's totally chaotic. And then vascular invasion, right? That's a huge one. If you see tumor thrombus in the portal vein or the hepatic vein or invasion into the IVC, you are almost guaranteed to have significant shunting.
Because the tumor has physically eroded into the drainage system.
Right. But there's one specific sign mentioned in the lecture that I thought was cool, the Phasic CT sign.
Okay, tell me about that.
Yes. So this is subtle, but it's diagnostic. You're scrolling through a standard triphasic CT liver.
Mm.
You are on the arterial phase. Aorta is bright white. Hepatic artery is lighting up.
Mm-hmm.
Normally, at this split second, the veins should still be dark.
Right, the blood hasn't had time to get through the liver and back to the veins yet.
Exactly. But if you suddenly see streaming of contrast appearing in the hepatic vein or the portal vein at that exact same moment,
That shouldn't be there yet.
no, it shouldn't. That means blood is bypassing the capillary bed, bypassing the sinusoids, and shooting straight from the artery to the vein through a fistula.
And if contrast can do it,
Microspheres can do it.
Yeah.
And if it's in the hepatic vein, the next stop is the right atrium and then the lungs.
that's a great tip. You see that, and you know you're in for a rough mapping. Okay, so let's say you've spotted the risk. You do the mapping, and comes back. Lung shunt high, 30 gray exceeded. Now we open the playbook. Mitigation Strategy A.
Balloon occlusion.
This makes intuitive sense to me. If the door is open, slam it shut.
Precisely. The concept is just to physically block the venous exit so the particles cannot float away to the lungs. You place a balloon in the hepatic vein, inflate it, create a seal. The blood and the Y-90 is forced to stay in the liver.
Does it actually work? Like, how effective is it?
It's effective. The data suggests it reduces the shunt by an order of magnitude. So if you have a 20% shunt, balloon occlusion can drop that to 2%. You are essentially just moving the decimal point over.
So it turns a contraindicated patient into a safe candidate. That is huge. Okay, so walk us through the technique. You're not just floating a balloon anywhere.
No, you need to be strategic. Usually, for these large tumors, you're doing lobar treatments. So you need to block the outflow of that entire lobe. That typically means putting balloons in both the right and middle hepatic veins.
So double stick in the neck.
Often, yes. Double stick the jugular vein. And there is a pro tip here that is easily missed. Do not forget the inferior right hepatic vein.
The accessory vein.
It's present in about 10% of people. It drains the posterior segments of the right lobe directly into the IVC by passing the main hepatic veins.
So if you block the main highways but leave that back alley open.
You might still get significant shunting. You have to actively look for it and occlude it if it's there.
Got it. And what about the balloon itself? Just any balloon?
No, you want a large compliant balloon. You do not want a non-compliant high-pressure balloon
And why is that?
because you need it to conform to the odd shape of the vein. And this is crucial. You inflate with air, not contrast.
Why air? That sounds counterintuitive in an angio suite.
2 reasons. 1, air is softer. It conforms better to the vessel wall without traumatizing it. 2, it keeps the fluoro image clear so you can see what you're doing. But mainly, it's about compliance.
And how do you know it's working if you can't see the air on X-ray?
You verify the seal. You inject contrast through the balloon catheter or the sheath to make sure there's no washout. You want to see the contrast just pool and stagnate.
If it washes away, your seal isn't tight enough.
Exactly.
Got it. So balloon occlusion is basically the go-to for the close calls.
Right. If a patient is at 35 or 40 gray to the lung, balloon occlusion is perfect. It brings them well within the safety margin.
Okay, but what if the shunt is massive? What if a balloon isn't going to cut it? Now we have to get aggressive. Mitigation Strategy B, embolization.
This is where we start talking about dicey options and heavy-handed options.
Let's start with dicey. Glue.
The technique involves running 2 microcatheters in parallel, one for your Y-90, one for the glue. You deliver the Y-90 dose, and then immediately, and I mean immediately, inject glue to freeze the arterial tree and trap the Y-90 inside.
Why is that so dicey?
Timing. We are talking about a window of a couple of heartbeats. If you are too slow with the glue, the blood flow just washes the Y-90 through the shunt and into the lungs.
And if you're too fast?
You glue the artery before the Y-90 is fully delivered, and you've underdosed the tumor. It requires such perfect synchronization that it's it's not widely recommended.
Yeah, that sounds terrifying. So let's maybe skip the glue. What's the heavy-handed option? Using TACED to plug the shunts before the Y-90.
This is a very common strategy, but it has a massive trapdoor that people fall into.
What's the trap?
Using small particles. Not only does it not work, it can actually increase the shunt percentage.
Wait, how does embolizing make the shunt worse? That doesn't make any sense.
It's fluid dynamics. Think about it. You have a tumor with regular microvasculature and then these giant fistulas, the shunts.
Okay.
If you throw in small particles, they plug up the small, healthy-ish arterials. They increase the resistance in all the normal pathways, but they're too small to plug the giant fistulas.
So blood follows the path of least resistance.
Which is now exclusively the giant shunt you failed to plug.
Okay.
You divert more flow through the shunt. The source describes a case where the shunt went from 45% up to 50%.
Wow, you actively made the patient less safe.
Right.
So what is the fix?
You have to go big. You need very large particles, gel foam slurry, large permanent embolics. You need to physically plug those large holes. You have to be aggressive. Don't mess around with the small stuff.
There's one more embolization target mentioned.
Varices.
Yes. Sometimes the shunt isn't going straight up the hepatic vein. Sometimes the blood whooshes around into the portal vein and then drains out through gastric varices or other collaterals.
So plugging those varices can help. It can. It's not a magic bullet. It usually gets you maybe a 10 to 20% reduction. But in a game of inches, that might be enough. If you see big gastric varices, coil them off.
Okay, so we've got balloons, we've got aggressive embolization. What if neither is an option? What if the patient is elderly, frail? Is there a medical way out of this?
That brings us to Mitigation Strategy C, systemic and dose adjustments.
Let's talk dose reduction first. Can't we just give less Y-90?
You can. Homeopathic Y-90, as it's jokingly called. But the problem is efficacy. If you lower the lung dose by lowering the total dose, you are also lowering the tumor dose.
So you save the lungs but fail to kill the cancer.
Right. It's generally not a recommended primary strategy because the response rates just tank.
So what about systemic therapy? Drugs?
This is the long game. Tyrosine kinase inhibitors, or the newer checkpoint inhibitors, there's evidence these drugs can reduce shunting over time by normalizing the tumor vasculature.
But time is the key word there.
Yes. It can take up to a year. This isn't a fix for a patient who needs treatment next week. This is for that borderline patient, maybe a 70-year-old with a massive shunt, where you say, let's put you on systemic therapy, wait 6 to 12 months, and see if the shunt cools down.
A valid strategy, just a slow one.
Exactly. Requires patience.
I want to pivot now to the end of the lecture where they really get into the critical analysis. Because we started by talking about how old the rules are. And there are some paradoxes in how we even measure this stuff.
Yeah, this is where it gets really interesting for the physics nerds. We have what the source calls the 1 kilogram fallacy.
Which is?
Current dosimetry, the math we use to calculate dose, assumes every human being has a lung that weighs exactly 1 kilogram. And it assumes the particles spread out perfectly evenly throughout that 1 kilogram.
Which we know isn't true.
Of course not. And as we discussed earlier, the particles don't spread out evenly, they cluster in the middle. So locally, the dose in that middle area is actually much higher than what we calculate on paper.
So we're underestimating the local damage?
In a way, yes. But then there's the measurement paradox that swings the other way.
Right.
When we do the MAA scan, we usually use 2D pictures. The liver sits right next to the lung, so the scatter radiation from the liver shines up into the lung field on the image.
So the camera thinks there is radiation in the lungs, but it's actually just scatter from the liver.
Exactly. So in that case, we're overestimating the shunt. We think it's higher than it really is.
So we have one factor underestimating the danger and another factor overestimating the danger.
And the conclusion is that they sort of cancel each other out. It's imperfect, but it's the system we have. It works well enough.
There is one final distinction that seems really important regarding glass versus resin microspheres. The guidelines treat them similarly, but the real-world data paints a different picture.
It really does. The literature suggests that radiation pneumonitis is much more commonly reported with resin. There are even reports of RP occurring in resin patients who received less than the 30 gray limit.
Scary. So the limit might not even be safe for resin. What about glass?
Conversely, operators report pushing glass significantly higher than 30 gray, sometimes well above, without seeing RP Riyadh and others have data on this.
So the 30 gray limit might be too loose for resin and too strict for glass.
That is the prevailing thought. The field urgently needs to bifurcate these guidelines. We need a specific safety limit for glass and a specific, probably stricter limit for resin.
It sounds like we are treating patients based on a one-size-fits-all model that doesn't actually fit anyone perfectly.
We are. We're managing 2026 medicine with data from 25 years ago. The future has to be personalized dosimetry. Not just 30 gray to the lung, but how big is this patient's lung? Where are the particles actually going?
Moving away from the arbitrary 30 gray wall.
Exactly.
So let's bring it all together, the high lung shunt playbook.
Number one, if it's a close call, use a balloon. Block the exit. Don't forget that accessory vein.
2. If it's a massive shunt, do not use small particles. Go big with embolization or you'll make it worse.
3, if you have time and the patient is stable, consider systemic therapy and wait. And 4, understand the limitations of the data. Use your clinical judgment. If you are using glass, you might have a little more wiggle room.
It's amazing how much nuance there is in just that one number on the report. It really shows why IR is as much an art as it is a science.
That is the essence of the job. The guidelines protect you legally, but understanding the pathophysiology protects the patient.
Well said. This has been a fascinating look into the weeds of Y-90 safety. Hopefully the next time one of you listeners gets that lung shunt 20%, you won't panic. You'll just reach for the playbook.
And maybe order some large balloons.
And some large balloons, definitely.
Hey.
A huge thank you to the original lecturer, Dr. John Louie, for providing such a candid and practical guide.
Absolutely. Essential knowledge for anyone scrubbing in.
That's it. Thanks for listening.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.